I have no disclosures. I'm actively seeking disclosures. So let me know. In terms of objectives, we'll kind of discuss the current workup strategy of newly diagnosed small renal masses. Most of it is cross-sectional imaging based. We'll review the current state of nuclear imaging in the workup and the management of it, and then we'll kind of discuss the future directions of this. So with the rise of cross-sectional imaging, as we all know, in the 80s, there was this huge spike in the rise of kidney tumors. And us as urologists got all excited because we're like, we're finding all this cancer, we're going to cure all of it. And there was this big stage migration towards localized disease. But then as things the data started to trickle out many years later, you actually found that even though you were finding more, the mortality rate was going up. So there was kind of this like gut check of like, well, we're treating more, but actually more people are dying of it. So then there was this paper that kind of came out that kind of adjusted the cancer-specific mortality to the actual incidence. And it found that more people are dying, but we're actually finding more. So it all kind of levels out. But at the end of the day, still, we're treating more, but we're not really having an impact on mortality. And that kind of gives you the idea of, well, maybe we're treating, tumors that don't really need to be treated. And there came this idea of kind of fear of overtreatment. Out of that was born active surveillance for small renal masses, which now is a very well-established thing, but even like 10, 15 years ago, really wasn't, mostly retrospective data based until this DISARM registry came out of Hopkins, which was the first real prospective way of looking at delayed intervention versus surveillance for these small renal masses. They showed, and this is only like 2 to 3 years, but they showed that there was essentially no difference in cancer-specific survival, which you wouldn't expect there to be. But back then, it was still kind of a major question. Looking out of the patients that did end up crossing over to delayed intervention, the 21 of them, there was like, I think 4 of them or 5 of them that were oncocytomas, the rest were renal cell carcinoma. So the ones even that went on active surveillance ultimately got delayed intervention. It was like a quarter of them were actually not even malignant. So this kind of, at the basis of the whole talk, basically, is our limitation in the fact that out of 10 to 15% of the renal masses that we cut out, they are benign. And we don't have really any way to identify that 10 to 15% prior to imaging. And we'll kind of talk about the nuances of that today, but about 5 to 10% of them end up being oncocytomas. And the total like 10 to 15% of low malignant potential also includes something called chromophobe renal cell carcinoma. So the harsh reality of this is, like I said, about 10 to 15% of surgeries for small renal masses represent overtreatment. So there's lots of fishes in the sea. And some threats are quite obvious. You have this huge renal mass right here. It's very obvious what needs to happen to that. But some are not. This is the same mass in 6 different scans. Some of these, actually like 10 to 25%, represent minnows, something that you should just let swim right by and not bother anybody. Those are oncocytomas, lipid poor angiomyolipomas, and other malignancies, such as chromophobe RCCs. Then you have about 60 to 80%, which are malignancies, but they're indolent cancers. So when somebody in their, say, 50s or 60s, you'd want to treat it. Somebody in their 70s and 80s, you'd want to just watch it for a longer period of time. And then there are these 10 to 20%, which represent man-eaters, even though they are 3 to 4 centimeters in size. And those are the ones you really want to identify. So we've looked at renal mass biopsy. I have this discussion with all my patients that have a small renal mass, because there's some, like prostate cancer, we biopsy everything, and biopsy drives treatment. In kidney cancer, it's completely different. And mostly because there's this 10 to 15% non-diagnostic rate. And most people are not willing to accept a 10 to 15% rate that we're telling them they don't have cancer, but they actually have cancer and they don't get it treated. Otherwise, the positive predictive value, the sensitivity, specificity is like really not bad. but this non-diagnostic rate really kind of holds back its utility in clinical practice. So then the question is, would we be able to use, this is the only part of AI in my presentation, by the way, is this image right here. I got this from Chatbot, and it was not very sophisticated like what Dr. Nguyen is doing. But can we use basically imaging, specifically to this talk, nuclear imaging, to try to chip down on that 10 to 15% of benign resection rate? So this is where kind of Sestamibi SPECT CT comes in. 99 MTC Sestamibi is basically, a molecule right here, which gets uptaken into mitochondria and then shows up on your nuclear imaging. So normal renal parenchyma, the mitochondria density is normal. So it's basically our tracer uptake reference, like the background. Oncocytomas, though, are very dense with mitochondria, and so they uptake a lot of this Sestamibi, shine bright, and that's positive. Whereas clear cell has very low oncocytoma, very low mitochondria density, and so their tracer uptake is low. Based on that, you can have, this is an example of a Sestamibi image here. You have a hot scan. So this is we know, that it's an oncocytoma, and you can see how it shows up right here. Whereas on a negative scan, cold, i.e. renal cell carcinoma, you get this dropout of signal right here and right here because they have low mitochondrial content. So this group from Hopkins, led by Goran, looked at this first with Sestamibi SPECT CT scans, and they basically, their model for their paper, they had like 60 or 70 patients that were planned for surgery, and then they did SPECT CT for all of them, and then compared, looked at accuracy of tests. So this will come back later. So kind of try to understand this idea, the relative uptake. So basically, this is their tumor to background ratio of how they interpreted at a mathematical level the percentage that the nuclear scan was positive. And so they came up with a cutoff of 0.6 of relative uptake. And with 0.6, the ones that did not uptake were predominantly renal cell carcinoma, or AMLs, with these two false positives up here. And then the relative uptake was higher for those that were oncocytoma HOCT. And this data looks really good. And when you dive into their data a little bit deeper, they called a positive test one that lit up and that was consistent with an oncocytoma. And their sensitivity was 87.5%, specificity was 95.2%. They had two tumors that were false positives, so meaning they look like oncocytomas, but they were actually malignancies, but it's because they were chromophobe RCCs, and chromophobe RCCs have some histopathological kind of overlap with oncocytomas. They're kind of considered this hybridized oncocytic type tumor. They're in that wavelength. So they have more mitochondria. You could see how they could kind of like slip through the cracks as a false positive. So since Goran's initial paper in 2016, there's been 8 different studies that have kind of come out that have looked at this in particular, and they, the metadata shows that like sensitivity is 89, specificity is 91, negative predictive value is 98. So it like looks pretty positive. But the only problem with these is that they have pathology for everyone like this. So it's perfect for initial testing characteristics, but it tells us really nothing about how this imaging could work in a real world clinical setting. Because we're not going to get Sestamibi images on everybody that has a small renal mass. So how is it going to work when you try to use it actually in the tool belt of imaging in a clinical setting to try to determine in the patients that you really need to know, is this person have a malignancy or is it not? Some are just obvious. Like I said, you just go straight to surgery. So when I was a fellow at Fox Chase Cancer Center, we looked at our experience with Sestamibi. So we got very excited because they were using this imaging, and we thought, man, this is a way to bring down our benign resection rate down from like 10 to 15%. So we started doing Sestamibi imaging on everybody. But not everybody that we did it on ended up going to surgery because we had a very, robust active surveillance protocol. And some ended up getting biopsied, some did end up going to surgery. So retrospectively, we looked at those that we had tissue on and then compared them with kind of accuracy models to it. And what we found was that 20% of patients that had a cold sesame imaging suggesting that it was cancer, like 20% of them were actually wrong. And 20% showing an oncocytoma is actually worse than the 10 to 15% that you operate on. So it doesn't really move the needle with regard to that. There were limitations to this study. Obviously, the N is fairly low. The number of hot masses was low because, again, oncocytomas only represent about 10% of small renal masses. And one of the big critiques of this paper was that we had used qualitative interpretation. We used basically 2 nuclear medicine radiologists that gave a qualitative, which has been previously well described about, does this look hot? Does it look cold? But we didn't do TBR analysis to look at the tumor to background ratio. So after I left, they basically went back and performed tumor background ratios of all of these masses to see if we look at this at like a quantitative level, are we going to improve our ability and our accuracy of the test in a clinical setting? So this is a busy slide, but this is the qualitative analysis. And then we use all of the tumor to background ratios that had previously been described as being effective. And then we ran our data through all of these tumor to background ratios. And the take-home point basically is you see these negative predictive values all more or less being in kind of the 80s, upper 80s, gets better here in the middle, and then a little bit worse at the end, but this false positive rate really varies a lot. As your negative predictive value goes up, your false positive rate goes up too. So it's hard to thread that needle. And the one with the highest negative predictive value was actually the original tumor to background ratio that Gorin had published with in his original set in 2016. But if you look, his false positive rate, again, being a positive scan, but actually malignant tumors. So it's a scan that you say, oh, it looks like you actually have a benign lesion. We'll manage you, with surveillance. We're not going to operate on you. Like 4% of the time, those actually ended up being cancers, which is lower than if you just have a radiologist look at this qualitatively. And actually the negative predictive value is higher. If you look at the one with the lowest false positive, so the lowest false positive using a tumor to background ratio was actually on par with a radiologist's own eyes. And the negative predictive value was actually a little bit lower. So I think what this study basically said was qualitative analysis is effective, and trying to look at it mathematically doesn't actually improve your test characteristics. This is another way kind of to look at this, and I think this is a good slide because concordant basically is the number of oncocytomas, the number of hot scans that were likely oncocytomas that ended up being oncocytomas, the number of cold scans that suggested a malignancy that actually came out as a malignancy, and then you have your false negatives and your false positives. And you can see basically the qualitative approach on the original paper right here, and then this 0.6 TBR are more or less like very similar with qualitative versus quantitative. So I guess the take home for those 2 papers is basically, how sesame imaging actually moves the needle in the clinical setting where you would actually utilize it in patients that you need to be able to differentiate benign versus malignant is just not ready for real world clinical practice. I think that there is potentially a role. I think that we need to improve the accuracy in real world practice, tried to kind of go and look at the patients that we're actually using the imaging on and how we can improve it with those patients specifically. We need to figure out what patients are the best patients to use this imaging on. And then also, I think we need to combine where we use multiple entities, maybe come up with some kind of composite score, a nomogram of imaging entities, add in renal mass biopsy in there so that, you know, maybe you'll have a suspicion score based on your CT scan. You'll have either a positive or a cold image on sestamivi, and then you have a biopsy. And when you add all three of those together, then the area under the curve of malignant versus benign would go up. So I think there is potentially a role for it, but certainly not something that I order on my patients here because it just doesn't really move the needle on a benign resection rate kind of in current practice.
Thank you, Dr. Schober. We really enjoyed the presentation. And we'll have questions available for Dr. Schober at the end of the next presentation. So now we're going to switch gears back to that all-common prostate cancer presentation. But I would actually I take pleasure in introducing Dr. Lisa Chaikin, who is an assistant professor in our department and is actually based in Sioux City and works at June Island Cancer Center. Dr. Patrice Cohen had also joined Lisa earlier this spring. But today, one thing that Dr. Chaikin has at June Island that I'm really jealous about is a PET scanner that Radiation Oncology kind of runs. And I'm very envious about that research opportunity that she has. So Dr. Chaikin is going to discuss prostate cancer treatment and PSMA PET imaging and essentially patterns of care at the June Island Cancer Center in Sioux City, Iowa. Thank you.
Thank you so much for having me today. It's always a pleasure to be here, and these are great conferences. Thank you, Dr. Lin and Dr. Ink, for the lovely introduction. I'm really privileged to work at the June Island Cancer Center. I have the hybrid of a very busy community cancer center and then all the advantages of being on faculty here with all of you and working with you too. And I have no conflicts of interest to disclose. And this is the June Island Cancer Center. We're kind of a hidden gem in Sioux City. And it's a pretty sizable center. I was really impressed when I came out here at first and got to know the place before I moved out here permanently. And just a few things about it. We're a joint venture in Sioux City. There are 2 hospitals and a hospice unit. We serve 15 counties in 3 states. We have 3 full-time hematology, medical oncology doctors, others that also help that have worked at the center before and come back for long periods of time. We're recruiting. Dr. Ink mentioned Dr. Cohn, who joined us in April, which is great. So 2 full-time radiation oncologists, nurse practitioners, many employees, and really close to, I think I skipped ahead, close to 40,000 patient visits. So sorry. Last year. So we're a very happening place, a lot going on. And what I wanted to talk about today is we do have the privilege of having a PSMA PET scanner right in the department, a PET scanner in the department that does PSMA, does regular PET imaging as well. And we're looking into advancing many other indications for PET. And it's really the only option. We draw from a 100-mile radius. So patients would either have to travel here or to Sioux Falls. And what I found most striking and what I want to impart to you today is how it's really changed the whole paradigm of how we've treated prostate cancer. Sometimes the simple SIM turns into 4 SIMs because you have all these different sites that you've discovered. It's changed how we set up patients, and it's really become an important tool that we've used in planning for our treatment. And it's also opened up treatment modalities. Patients that have positive PSMA tests can potentially, for patients that qualify, and I'll touch on this at the end, for Pluvicto. I'm also very grateful for not only the radiation oncology department, but also the radiology department, nuclear medicine, that has helped set this up, has proctored me for Pluvicto, and reads our PET scans, not only the PSMA, but all of our radiology done in the department, our CTs and PETs. And because these are very subtle findings, they're sometimes hard to find even when they put the image number down, and they've been so kind going over the images. You know, we get on the phone, we can see everything and go through it together to make sure it's very accurate. So that's been a huge benefit too of having the backup and support of UNMC. So just a little bit about where we are. We are in Woodbury County. Let me see. Is there a pointer? No. Yeah, here we go. We're in Woodbury County, which is up, see if I can point it out here, right over here. So you can see that we have a higher, this is new cases. And just in general, we're kind of higher for the state. That may be population based, but still significantly higher than many of the other numbers you see. And prostate is about 13% of our new cases. And for cancer deaths, we're also in the highest level, 205 here. And prostate being a fairly favorable tumor is 5.5%. We do see a lot of lung cancer, which is the number one at 23%. So we do have a real need to have good cancer services in the county and surrounding areas. And these previous slides were courtesy of the Iowa Cancer Registry, and also this also from the Amanda Call at the Cancer Registry in Iowa presented some of the just basic data from our prostate patients. And you can see that there's 22% Gleason score or less. They didn't subdivide the Gleason 7s, and just about 25% of the high-grade lesions, 8 and above. A lot of patients get surgery. I thought the number was low for surgery and radiation because we do have a large urology group, and they do send many patients and work with us quite well. And most of the patients are localized. But kind of keep those Gleason scores in mind when we look at our data. I wanted to look at patients when I arrived on February 1st and until just recently. And there were 119 patients with prostate cancer that were seen and treated in the department. And 88 were primary and 31 were post-prostatectomy. And we only had 6% Gleason 6s, lower than what was in the Iowa registry. And we had a higher percentage of Gleason 8s and 9s than they had shown in the slides before. Our Gleason 7s were pretty evenly divided, but a little bit more of a high-risk population, which has been my impression with patients there. This is our machine. It was a huge fundraiser and an investment in the community. We had one on a trailer before, and it's able to do much better quality, increased speed, less radiation, and we're looking to advance many uses for it. And of course, having the great radiologists here to help us read and interpret these findings. And this slide's a little misleading, but when we started in 2021, there were only 19 cases, then it jumped up to 164 and 222 in 2023. But in 2024, it looks like we're lower, but that's only through May. We actually think that we will far surpass the 222 scans that are done. Not all of these patients are seen in radiation oncology. Many of them are staged for surgery, and many of them come from other areas of the state. So I just wanted to go over the literature, just some key studies that I thought were interesting. And this is, of course, phase 3 data from the Condor study, which was a major study in terms of looking at post-prostatectomy patients with recurrence and with prostate cancer, and had PSMA testing, multi-institutions throughout the United States. And they looked at 208 men, PSA of 0.8. And just some numbers to keep in mind. They said that a total of 63.9, 64% of evaluable patients had a change in treatment management. And 59 to 66% had at least one lesion detected. And they've concluded that it really provided clinically meaningful and actionable data in terms of treating patients with recurrent prostate cancer. This was after prostatectomy. This was also, I thought, an interesting study from Germany, looking at, again, at post-prostatectomy data. And when they looked at this, 87%, so we went from 64 to 87%, had a change in the radiation. Over 50% had some change to the prostate bed, 58% to nodes. And, you know, some nodes that we don't typically treat, like presacral, paravesical, pararectal, some of these nodes we would probably be excluding because we're trying to keep our bladder and rectal doses down. So it made a huge impact. So very high numbers. And a study from UCLA with the prostate intact that looked at changes. This is a little more complicated slide, I apologize, but 34% of patients had a change in lymph nodes and 10% were upstaged with distant metastases. Again, lymph nodes kind of all over the place. And some of them were much higher, abdominal, upper diaphragm, perirectal. We've seen more presacral. They only had 1.5%. I'll go into that in a minute. These were clinically significant, 6 millimeters, were able to show up. And they had changes significantly, even when they were treating prostate, seminal vesicles, and lymph nodes, 37% still needed additional changes in their treatment fields based on the PSMA findings. And even patients, 16% had changes when they were treating lymph nodes, and when they were treating the prostate alone with seminal vesicles, close to 40%. So a real impact from the scans. So what are our statistics? Again, this is our group, 88 primary prostate patients and 31 post-prostatectomy, and our breakdown of Gleason scores. And what we found is the majority of patients, 82%, were actually, you know, in favorable groups. PSAs less than 10. Some PSAs were a little higher, but basically very favorable. And a majority of patients were stage 1 and stage 2 of presentation. And this is before they were upstaged from the PSMA. What we did find is for the intact gland, unfortunately, 61% did not have PSMA for staging. But I can tell you that's been changing, and that's the radiation oncologist ordering. I think it was getting our startup, getting used to authorization processes, but we are ordering a lot more. I know I am, and we are seeing patients come in with intact glands that are in that decision-making process between surgery and radiation. But 34 patients did have PSMA tests, and close to 74%, 25 of them, did not show beyond the prostate gland, and confirmed really the MRI findings. Most patients did have MRI. I don't have that on the slide, but most correlated well. However, 26%, 9 patients, had positive findings that were different from conventional scans, and either an MRI, or not all patients had CTs and bone scans before they had the PSMA. Sometimes they went straight to PSMA, but most patients did have an MRI of the prostate and pelvis. And of these, 2 patients had oligo bone mets, so certainly changed our course of treatment. 4 patients were upstaged with lymph nodes that were treated and boosted. 2 patients, seminal vesicle involvement that was not seen on the MRI. And 1 patient got all 3 and really turned into a very complicated simulation, but it was very good information to know. And what I don't have on the slide is that there were some patients that had a bone scan. There was a questionable rib met or questionable bone met, and we did the PSMA, and that was found actually to be negative. And so we felt much more comfortable with that. For post-prostatectomy patients, our urologists were the primary physicians ordering, and they did better than us. Only 3 patients did not have PSMA tests, so they were really good high users. 28 patients did. 6 patients were negative. 21%. And the only caveat I'll say about that is sometimes with patients, when they hear they have a negative PSMA test, they don't want any treatment, even if their PSA is above 0.5 or, significant. So we have to educate them that this is a tool and that's good news, but it doesn't mean that they don't require radiation treatment. So 22 out of 28 patients did have treatment modifications, and we're at 79%. We're right between the 64% to the 80 some odd percent. So we really benchmark with the data that was shown, and lymph node only in about a third. Even prostate bed, we picked up another 18% alone, another 11% with lymph nodes. One patient was just a oligomet. Prostate bed and bone, just a few patients. I know these numbers are small, but they are interesting. And for the specific patient, it really made a huge difference in how we plan their treatment. So I wanted to give you some examples of how it did change. So this is a post-prostatectomy patient and had pararectal nodes, and these were boosted up higher to get a fuller dose. Normally, probably would have been excluded. And these are some fused images, and I apologize, I went back and forth on how to display and what images to use, but this is fused with the PSMA. But you could see some of the bony outline of the pelvis, the sacrum here. This is the presacral node, and it does show up, and it's usually a node that probably could have been excluded or at least underdosed and then was boosted with treatment. And we're able to dose paint with our ability with IMRT and even still treat these patients with complicated treatments with moderate hypofractionation, so they can finish within about 5.5 weeks with a 28 treatment regimen. Additional lymph nodes that were boosted in addition to covering the lymph nodes in general, and were boosted up higher with higher daily rates. This is a patient that was post-prostatectomy and had a small area in the prostate bed that was boosted higher that we would have never known about otherwise. And here's the bones of the hip and pubic symphysis or ischium. We found, I know it was interesting, when I was trained in medical school, we always thought about prostate cancer kind of marching up the spine, starting at the lumbar spine up. Here, the bone mets have been in many different places, a lot over the right iliac crest, and we were able to boost that at the same time as the nodes. And these are our treatment lines for therapy, and the bony anatomy here with the sacrum and iliac crest. So the small area that you can see is bright was hot on PSMA. And the bone metastases were kind of unpredictable. This was an isolated scapular met that was treated. And during the course of the 28 treatments, we would give it 3 or 5 fractions to complete therapy. This was a pedicle met that we treated during the time of definitive radiation, an oligomet, and a rib met as well. Not the typical places that we would expect to see prostate cancer metastases before PSMA tests. And of course, we did see vertebral bodies occasionally. And another case of an iliac crest too close to our fields to give an SBRT approach. So we integrated it in and treating at the same time the nodes. And these are different snapshots in time. There'll be additional cone downs that'll bring other areas up to full dose. And this was a node that kind of jumped. The patient had pelvic nodes. This was a post-prostatectomy patient, and it's rare that I've treated prostate cancer up with the kidneys, but this was a definite no, confirmed with radiology, and we also boosted that as high as we could given the kidney and bowel constraints. But something that would have been completely missed, and this patient did have CT imaging, pelvic MRI, but abdominal and pelvic CTs that did not show this at all. So really changed the course of treatment. So I'm going to switch gears a little bit and just talk about Pluvicto. So if patients are able to test positive on a PSMA test, there's now the development from that marker for a therapeutic treatment, which is Pluvicto or lutetium, and it's a radioligand therapy. It's 6 treatments that are given IV every 6 weeks, pending tolerance. And from what I've seen from my experience here, has been very well tolerated. And because these are older, typically older patients and heavily treated patients. And there are radiation precautions and teaching, but very manageable. So patients that qualify for this have to be castrate-resistant metastatic prostate cancer and must have failed at least one chemotherapy regimen or at least seen chemotherapy. And that's been very hard in our community because many of the patients are very sick and they're not chemotherapy eligible. They have kidney problems or liver problems, a lot of comorbidities that we've seen. And so it's been a rarefied group. I was really hoping by the time of this talk that we would have treated someone with Pluvicto at our center. We have had 2 patients that were up for evaluation. And I always say things are always a little unusual in Sioux City in our clinic, and both had brain metastases picked up. And I'm going to show a picture of that in a second. One of them had incontinence and is possibly going to come to UNMC for treatment because it's more difficult with the radiation exposure and leakage with the incontinence, and there have to be certain calculations done. And the other is still in trying, may not be completely castrate resistant. They have to have PSMA positive disease. And this is now available not only for bone, like Sovigo was really just bone limited, but we can use bone, nodal, and visceral metastases. So a much broader range of patients that we can treat at the center. And these are just courtesy of the Pluvicto website that, you know, based on basic standard of care, there is a better overall survival, relapse-free survival, and response rates, where we've seen PSAs that I've seen in the patients that I've been proctored on here were pretty dramatic results in terms of the PSA going down, which is always very reassuring to the patient. And these patients really had very limited treatment options. So one of the patients that I saw that was being considered had 9 brain metastases picked up by the PSMA test. And this was just one image showing about 4 of them. They were really spread out throughout the supratentorial, and I think one in the cerebellar area too. So something that we really wouldn't have known of. He wasn't particularly, he's very sick as it is, so it's not something we usually think about in terms of prostate cancer. And so I just went to see, you know, what is the experience with Pluvicto. In talking to the staff here, it seems that if it can be detected on the scan, it would certainly be eligible for treatment. And an interesting article came out from France. It was just a case study of a patient reporting like a hangover effect after about 4 treatments of Pluvicto. And what they found, because the patient was so tired and it seemed unusual from the other patients that they had treated, is that this patient actually had brain mets and even leptomeningeal carcinomatosis when they did a full workup. And the Pluvicto was having a significant effect on those lesions and causing a significant amount of fatigue. And it's interesting that this may be another, it crosses the blood-brain barrier, may be another way to treat patients that have brain metastases, that we don't want to rush into whole brain radiation, and they may have too many for a stereotactic radiosurgery. So it was a very interesting finding, and it was interesting that of the 2 patients that were almost Pluvicto candidates, both had brain metastases. So what is the future? Well, I think we definitely want to use PSMA more for intact prostate glands. I think we want to get as much information as possible. We may be underdosing or undertreating. It will help us, I think, come to a new paradigm on when we treat nodes or not, because many of these patients may not have qualified or reached the statistics with using Pardon tables and other things that we use. And better staging, one of the things that we want to extend at the June Island Center is we treat a lot of farmers, and they're very limited sometimes depending on the season on when they can come in, and having the 5-fraction SBRT. We do offer that, and we've treated a handful of patients, and it will give us more confidence to know that we're really treating all that there is. But sometimes it's been limited because many of the patients do have more advanced disease, as you saw kind of the shift to higher PSAs. Certainly, we want to be able to offer Pluvicto for our patients so they don't need to travel as far. And these are patients that, even though heavily treated, many prostate cancer patients are still in good shape. The 2 that we've had so far have had brain metastases, so they're a little more limited. And of course, we're also fortunate to have from UNMC genetic counseling available for our patients through telemedicine, and maybe just screening more of these higher risk patients that we see and get down some of those statistics that I showed you earlier from the Iowa Cancer Registry in terms of cancer deaths, and maybe more detection, but being able to treat better and more thoroughly and screen our patients better. So with that, I'll open up Dr. Ink for questions. Thank you for your attention and appreciate the opportunity. Sorry.
Thank you, Dr. Chaikin. And Dr. Schober, if you could join us as well. So we'll try to get through as many of these as we can, but the first one, Dr. Schober, is for you, and that is, are there specific patient populations that you believe would benefit most from the use of SPECT-CT in renal mass evaluation?
Yeah, so really it's that, like, there's 10 to 20% that are obviously like malignancies and need surgeries. And then there are the minnows. And we're really trying to find those minnows that represent like 10 to 15% of either very indolent or just benign patients, and specifically more in the small renal masses, kind of moving forward, because we already know that small renal masses have a very low malignant potential. I think that's the first thing kind of to tackle. But we also know that that large masses, 7, 8 centimeters, a certain number of those actually are indolent or benign as well. But I think it's harder to stomach not treating and enhancing heterogeneous 8 centimeter mass than it is watching like a 2 to 3 centimeter. So.
And the kind of the second question kind of follows on that too. So what's been the impact of 99M SPECT CT imaging? Have you used that to actually reduce unnecessary either biopsies or surgeries based on, what you see on PET imaging?
Which is a really good question. And that's why, 5 years ago, we implemented it into the workflow for like basically all small renal masses at Fox Chase Cancer Center, in hopes that we could find a signal in terms of people that were going on active surveillance, that we could reassure them, or though we could prevent people from going under the knife for resection, or getting unnecessary biopsies. And then we looked at our data retrospectively of like about 80 patients and found that, the testing characteristics that had previously been published in a real world setting are worse than using CT imaging in current practice to identify patients that need a surgery. And if we use system EV scans, we would end up taking more people to the operating room that have benign masses than just current practice. So to answer your question, we don't really use it at all right now.
And then Dr. Chaikin, so, radiation oncologists like yourself, medical oncologists, and even include urologists at Dakota Dunes. How do you handle PSMA PET avid nodes that otherwise would not meet criteria? Their short axis is under a centimeter. Do you, for example, give more enhanced systemic therapy based on that when the node otherwise would not be called on conventional imaging?
Right. No, it's an excellent question. I do change my fields. I mean, if it is called, I'll always have a discussion with the radiologist and go over everything, but I do definitely change my fields and boost things and adjust dosing. And in a reasonable way, I won't track, all the lymph nodes up to the kidneys. We had a hard time with that setup, and we ended up kind of spotting that area because the field was so long. But
be more likely to refer them, for example, abiraterone or something.
Right. And so our urologists are fairly comfortable with prescribing more advanced hormonal therapies and often do, and they often will refer to medical oncology. So it is taken seriously both from the systemic and the radiation part. So yes, the treatment changes on both sides.
This may be hard to predict just because of time, but at least are you aware of in your review for the talk, has there been a difference in progression-free or overall survival with the use of PSMA PET imaging for prostate cancer?
Of course, my personal bias would be yes. But I did look at that, and it's a fairly new technique and people are integrating it. So there is certainly data out there. I didn't address that in the talk because I had such a short period without, long-term survival. I couldn't look, it was over a little over a year and a half. But there is some data to suggest it. We're going to need much longer term data because patients do well with prostate cancer. This is a new technique that is coming out. But I think it's going to take time to see that hard data, and it may take many years. But I think in terms of, covering disease that and you're able to do it in a way that's very acceptable from toxicity, given that we have the IMRT planning and the dose painting, that is very reasonable to at least give the patients the benefit of the doubt.
This actually may be a question that I ask both of you to weigh in on, and maybe Dr. Carmichael, who asked the question. So what are the potential risks or challenges associated with widespread adoption of PSMA PET imaging in clinical practice? Jerry, were you worried about, for example, over-treating based on PSMA PET, or what was the question?
I have to say, I have like a very kind of different perspective. I worry a lot about financial toxicity, and it also is a big burden on kind of the office staff with pre-approvals. I've gotten a PSMA PET scan on everybody, very strict kind of NCCN guidelines, anybody that is unfavorable intermediate risk or above for the last 2 years, and I have yet to find a positive one. And
Wow.
my like pathologic stage on resection of prostates is like the median is probably PT3A. So I see a lot of what I would call locally advanced disease that comes from central Nebraska, western Nebraska that I operate on that have a fairly high clinical stage, but a negative PSMA. So I think that we are imaging people that do not need to be imaged. And I think that we need to figure out who within that unfavorable intermediate risk disease needs to actually get the imaging, because there are a lot of people that I image that I don't think I need to. High risk is like, I mean, that makes sense to me. And I think that if you have high risk people with PSAs in like the 20s or 30s that have an MRI with clear like SVI involvement or like biopsy, Gleason 9 disease, like that makes sense. But these patients that have 7 out of 12 cores of grade group 2 disease that I'm sending for PSMA PETs are all coming back negative, and they're at a significant cost.
That's interesting. Yeah. I mean, I think it depends on the patient selection. We probably see, sicker, more advanced patients, although we didn't find a good correlation. Again, very small numbers and just my limited view since I've been there, but small numbers, but still, lots of stage 1 and 2s, lots of PSAs under 10, but a lot of bad disease that came out. And when you look in the, data from other radiation oncologists, it's been a very useful tool, especially in the post-prostatectomy setting where you're trying to find where that PSA is coming from. So it just has not been our experience or in our literature, but I think it depends which patients you're looking at. We may be seeing sicker patients, even though maybe they're bordering on hormone resistant and they're not tracking as well with the PSAs. But
yeah, I mean, like what you're saying is dead on. I think it's probably patient selection. People that, because the people that I get anybody that I biopsy that meets criteria, I get a PSMA PET even before I send to radiation oncology. But I'm not capturing those patients that have an MRI, which automatically shows SVI that goes right to radiation oncology with. There are certain patients that miss my practice, but I was expecting to find a lot more positives and haven't found any.
Wow. And I just wanted to do I have time for one other comment? Quickly, in terms of whether we're over treating, I mean, if you look at regular PET scanning, we are treating oligomets and different diseases from, and there are multiple, the SABRE trials and all that show that we can have potentially a curative impact with oligometastatic disease. And if we have just a different PET scan that's more specific to prostate, then it would seem reasonable to extrapolate that data is meaningful. And if we treat it, it could have also the same kind of survival and control benefit.
And I guess the last question I wanted to ask Dr. Luba.
I
So-
don't have a question actually.
Oh,
I just had a comment on the discussion.
well-
So just to kind of answer your point that I think in early stage disease, maybe PSMA PET scan may not be that much utilizable. And maybe that's where patient selection is absolute of paramount importance, that's what we need to learn. But as we talk about recurrent disease, I think that's where it is really, I would say, shining, because we are able to identify patients who we were calling biochemical recurrence only and having no idea, and then putting them on endless hormonal treatments versus now we have an option of definitively treating them and stopping hormonal therapy with good overall understanding of, okay, objectively what we did rather than just looked at PSA. So that's where I think it's really been helpful.
Yeah, no, that's where the majority of the data is too. that
yeah,
I found.
and we've certainly treated those patients without systemic treatment. I guess my question was, sometimes I've encountered the urologic medical oncologist in, let's say, an elderly patient, other medical comorbidities, their PSA is going up, and is conventional imaging with bone scan CT once a year just to make certain we don't need to do something versus, well, but a PSMA PET may find something. And I almost get the impression it's like, look, unless it's something really big and growing, maybe we don't want to know. Is that true?
Depends on the patient actually. I would really say, but I would say after talking to the patients, I think most of the patients do want to know what exactly is happening. It's a different story in terms of how aggressively we will treat them. But most of the patients, when given a choice, they will say, yeah, I want to know. And then I want to decide whether how much of treatment I can get and I can safely tolerate. So in that aspect, I think it's kind of helpful for patients in terms of understanding how much disease are we talking about versus just following a PSA number till we as a physician feel uncomfortable. Like, okay, your PSA is 30 now. I think it's time to treat, where there is no real correlation to it.
Well, that will end this session, but thank you, Dr. Schober and Dr.
Yeah,
Chaikin,
thank you.
and Dr. Luba for your.
Thank you.